Welcome to the lecture for Module 8 of our Medical Ethics Online course. For the last time, I'm Eli Weber, your instructor. And today we're going to be talking a little bit about euthanasia and physician-assisted suicide. Fittingly, I think, we're going to conclude the course by talking about issues that arise at the end of life. And before we sort of dive into the material, I want to just briefly explain why I think this topic is worth discussing. Oftentimes we hear about these extreme cases, the Terry Shivos and the Jack Kevorkian cases of euthanasia and physician-assisted suicide. And that can create a false impression that these are the contexts where this kind of decision can occur. But in fact, contemporary empirical data suggests that up to 70%, so 7 out of 10, hospital deaths are the result of some kind of decision to withdraw or forego treatment, which, as you're about to see when I give you some concepts and definitions, counts as a type of euthanasia. So, rather than thinking of euthanasia as a sort of fringe occurrence that happens every once in a while, and is mainly confined to these sensational Hollywood-type cases, you should think about this as an issue that is a regular part of medical care. Those of you who maybe want to work in pediatrics or podiatry will not have this problem, of course, but in general, 7 out of 10 hospital deaths do involve some kind of termination of care. So this is actually a very prevalent issue. And for those of you who are maybe interested in some kind of geriatric care or hospice care especially, this is just going to be a regular part of your life. So it's something you should really be thinking about. And if nothing else, it's something that, given that we're all going to die, and we all have loved ones who are going to die, and we all know people who matter to us who are going to die, this is something that we should at least think about a little bit so that we can be better prepared when the time comes to make our own decisions, if nothing else. Okay, with that in mind, we have 4 goals for this lecture. First, we're going to clarify the different types of euthanasia, as well as the specific ethical concerns associated with each. And the reason we're going to do that is, although there are ethical concerns associated with all types of euthanasia, most of the present debate is regarding active voluntary euthanasia. So a right of people to choose to take something to end their life. That's sort of the present state of the debate, and I'll compare that to the other forms of euthanasia that are available when we get to that point, and talk about why this is really the one that we are presently talking about. Okay, then we're going to consider a few different arguments for allowing patients the option of either active or passive euthanasia. So reasons to think that patients should be able to opt to end their life if they wish. We're going to think about some responses and criticisms of these arguments, and then we're going to conclude by talking a little bit about this sort of difficult distinction between killing and letting die. The thought is that this distinction is important for medical ethics because if something counts as a case of killing, it's morally bad, and if it counts as a case of letting die, that's going to be morally permissible. So some people think the debate about euthanasia turns on whether a specific act of euthanasia counts as killing or it counts as letting die. And I want to suggest that that's actually not very helpful. But in order to see that that's true, I think we need to talk a little bit more about how this debate has proceeded thus far. All right, let's start with some distinctions. There are a couple of dimensions along which you can divide different types of euthanasia, and then you can combine different categories as well to come up with different ways that this can play out. So the active versus passive distinction has to do with what action is actually required in order to bring it about. So what has to be done? That's what the active-passive distinction concerns. And for active euthanasia, for an act to count as active euthanasia, something has to be done to intentionally bring about the patient's death. So taking a deliberate overdose of some narcotic or pain or analgesic, taking or receiving an injection of some drug that is known to stop the heart or stop respiration or something like that. Lethal injection counts as active euthanasia. And in this case, in the case of active euthanasia, either the patient herself or someone else either performs the procedure that brings about the patient's death or assists in some way, sort of facilitates making that possible. Some of the Kevorkian cases, that's something that you can Google this stuff, and so there's tons of information about Kevorkian. But one thing that he often would do would be to sort of rig some sort of contraption that allowed the patient to initiate their own death, like some sort of chute that like pills and then water would go into, so that they could take the lethal dose of medication without anyone having to like administer it to them in a direct way. Something that allowed people to give themselves an injection even though they couldn't move other than like their hands. Stuff like that. But the point here is just that active euthanasia involves someone doing something with the intent of ending the person's life. Now, active euthanasia is not currently legal except in Oregon, and in Oregon only under sort of specific circumstances, and it's also legal in a variety of European countries. It's legal in Switzerland. So there's a video on the Blackboard site of a gentleman from Australia who went to Zurich in order to obtain legal active euthanasia. And there are several other countries where this is permissible as well, where this is permitted by law. It's still not permitted in a significant, a substantial number of countries. This is not allowed. And it's seen by some people as a morally problematic form of killing. This is the thought that what makes active euthanasia morally wrong is that it's a kind of killing. And that's a way to distinguish it from passive euthanasia. Now, passive euthanasia is just sort of the opposite in terms of what has to be done. Most cases of passive euthanasia involve sort of the cessation or withdrawal of treatment that's already being provided or could be provided. So something is going to count as passive euthanasia when something that's needed for continued survival is intentionally withheld or never initiated, and it's the absence of that needed something that facilitates the patient's death. Now, what's important here, the thought, and I want to really stress that this is just sort of the thinking behind this and not necessarily true, is that when we do something like withdraw the feeding tube or withdraw hydration or decline to treat something that we could treat maybe even relatively easily, the thought is that the intention is not to kill, not to bring about the patient's death. But I think there's a very real question of whether that makes any sense. Because if I know that withdrawing your feeding tube is going to lead to your death, it seems bizarre, if nothing else, to say, well, even though I intended to remove your feeding tube, I did not intend to bring about your death, even though I knew that that's what would happen. You might think this is I think actually the best reason to push against the killing, letting die distinction. It's not the things that Rachel talks about. It's the fact that this notion of sort of intending, the notion that passive euthanasia doesn't involve intending that the patient die. It's just sort of silly. But the thought is that what ends the patient's life in the case of passive euthanasia is lack of food, lack of hydration, or their disease, as opposed to the direct action of some drug. And some people think that that really makes a difference. You can probably tell from my tone of voice I'm quite skeptical that that does make a difference. But you might think that it does. So if you do, think about why that actually does matter. Now, passive euthanasia can include either non-treatment, as I mentioned, or the withdrawal of nourishment or hydration. There was a battle about withdrawal of nourishment or hydration, whether that counted as medical treatment. And so in some states for some time, a right to refuse treatment didn't include a right to refuse nourishment or hydration. That's now been changed. Usually the instigators of passive euthanasia are the medical staff, because often these are people who are incapacitated in some way such that they're not able to initiate their own end of life. And, in fact, we probably don't want people removing their own feeding tube or withdrawing themselves from supplemental hydration, just for sort of comfort reasons, if nothing else. I imagine that's not terribly comfortable. I don't think you can just pull that stuff out. So usually passive euthanasia does involve actions on the part of the medical staff. And for those of you who are considering going into nursing, this is something you should think about. Does the fact that what you're doing is allowing someone to die when you remove their hydration, does that make you feel okay about what you're doing? Or are you still troubled? Are you still conflicted? Do you still feel like there's something, if not morally wrong, at least difficult with it? I mean, we can think that something is difficult and not think that it's morally wrong. So keep that in mind, those of you who are going to become nurses, just as you move towards that, these types of scenarios, how you might feel about doing something like this for someone. Passive euthanasia is currently legal. It's regarded as acceptable within medicine because it sort of piggybacks on this idea that the patient has a right to refuse treatment. And further, this is seen as a less morally problematic omission. So there's a distinction between an act where you're doing something, there's an identifiable action, something that you have done, and I can say, you know, Stephen did it, versus an omission where all I can say is that you failed to do something. And the thought is that what makes passive euthanasia an omission is that the medical community fails to provide treatment or fails to provide nourishment or hydration, not that they actively ended the patient's life. All right, another dimension where we can divide up different types of, along which we can divide up different types of euthanasia, concerns these notions of voluntary, involuntary, and non-voluntary euthanasia. Now, and each of these categories can be combined. There's an active and passive form of each, and there's a nice chart in the reading that articulates all that in the Munson reading. But voluntary euthanasia, pretty straightforwardly, is where the patient consents to either active or passive euthanasia. So the patient says either, I want you to give me a lethal dose of morphine, or I want you to withdraw my hydration tube. And this can happen either directly, the patient is conscious, lucid, and we just ask them, or via either an advance directive or some sort of surrogate decision maker, like a spouse. Or an advance directive might specify, if I end up in this state XYZ where I'm not conscious, etc., and there are all sorts of ways to fill these out, I want my feeding tube or I want my hydration withdrawn. Those are going to count as voluntary euthanasia. And the thought here is that the patient has consented to what's about to be done to them. Now, involuntary euthanasia is a highly morally problematic category. I don't know of anyone who advocates for involuntary euthanasia being a practice in medicine, although there's a case you could make for it. It's sort of a scary one, but you could do it. But in the case of involuntary euthanasia, the patient explicitly expresses a desire to continue to live, but they're subjected to either active or passive euthanasia anyway. And one of the concerns that was briefly raised in the reading is that in Holland and in, I believe, I forget the other country, but definitely in Holland, there is a policy of non-prosecution of physicians who assist patients with suicide. And there have been some sort of troubling reports of involuntary euthanasia taking place. It's possible, and it's worth noting that this is possible, for this to come up within our own system, because we allow people to write advance directives stating their desires and preferences about end-of-life issues. Now, suppose someone had an advance directive where they said that they wanted to be allowed to die if they were in a situation where sort of their mental awareness and mental acuity dropped below a certain level. Now, it's possible, and say they had a terminal illness that required hydration supplementation or something, it's possible that someone in that type of situation might still have sort of expressed preferences to keep living. So if the severely demented person, when you ask them, do you want to continue to live, do you want your hydration tube, they say yes. Yet you have this advance directive that says, when I reach this point, and it's the point that the patient is now in, I want my hydration tube withdrawn. Is this involuntary euthanasia, or is this voluntary euthanasia? The thought is that this is voluntary because the patient has consented to it. What might make you think that it's still involuntary is that there is a patient in front of you, albeit perhaps not exactly the same patient that wrote the advance directive, or not very psychologically similar to that person. There is still a patient in front of you, and that patient is expressing a desire to continue to live. So there's some troubling concerns involved with advance directives and dementia, and one of the concerns that can come up is that it creates this possibility of involuntary euthanasia. But in general, we don't think, at least in the US, and even in Holland where there are concerns that this is occurring, we don't typically think that involuntary euthanasia is something that we need to take seriously as something we should consider allowing. That seems to put too much power back in the hands of the medical community, and we're going the other direction in terms of bioethics. The other category of euthanasia, where the consent of the patient is sort of what the distinction turns on, is non-voluntary euthanasia. And these are cases where it's unknown whether the patient actually would consent to euthanasia. Typically, the way that this is going to come about is that the patient is not conscious, there's no advance directive, and there's no officially appointed surrogate decision maker. So simply because the wife, or suppose a person doesn't have much family and the closest living relative is not a very close relative, you might think that that person is no longer in a position to speak on whether this patient would consent to euthanasia. And yet they still may have some legal grounds for opting for at least passive euthanasia. So non-voluntary euthanasia can come up in these sort of situations where we don't have advance directives and there's sort of limited family and that sort of thing. But ethically speaking, involuntary euthanasia, and what I want to do now is just sort of clarify what our discussion is really focused on, because people get sort of distracted by these other considerations. Involuntary euthanasia of all kinds is typically regarded as being deeply morally objectionable. I mean, you're going against the wishes of the patient and basically ending their life against their objections to that. That seems deeply morally problematic, and it's not really something that many people are discussing as a serious policy consideration. Although the issue that I just described about advance directives is something discussed in the bioethics literature, because it's a real problem. Very real problem in light of the amount of weight we place upon advance directives, and the fact that we can keep people with pretty severe dementia alive for a fairly long time if we wanted to. Another, just summarizing the ethical considerations that follow from these distinctions, active euthanasia is usually taken to be, that should be reversed. Passive euthanasia is usually taken to be less morally problematic than active euthanasia. Apologies for having that backwards here on the slides, but yeah, the thought is that passive euthanasia, because it's it's an omission, because it's a failure to do something rather than sort of actively ending the life of someone, is less morally problematic. The passive rather than the active, so just reverse the terms on that bullet point. Third, there are obvious cases where passive euthanasia seems morally worse than active euthanasia, and that's what what I'm thinking of in making that point is the case described by Rachel's of the child with Down syndrome who has the intestinal blockage, and the parents, because they don't want a child with Down syndrome, opts to go ahead and not treat the child and let them starve to death, or become dehydrated and die. Now that takes a long time. I mean, that's not like an overnight process. It's not a process of a few hours. It's a process of many days. That's a lot of suffering for a tiny, tiny child who has no idea what's happening. Now you might think, if nothing else in a case like that, if it is okay to engage in passive euthanasia in that case, it's unclear why it wouldn't be okay to go ahead and actively euthanize that child. Because once we sort of open the door to passive euthanasia in that case, there seems no good reason to refrain from giving the child something that will make their suffering less extreme. And so that's one of the worries and one of the possible consequences of allowing passive euthanasia that worries some people. It's just it's not clear why passive euthanasia is acceptable, active euthanasia is not. And so a great deal turns on this moral distinction between killing and letting die. Now my view, and you can disagree about that, is that at least in this one case described by Rachel's of the baby with Down syndrome with the intestinal blockage, it seems clear to me that letting that child die is morally far worse than simply engaging in active euthanasia, and that's in virtue of the suffering of the child. I would love to hear an argument for why that's not true, because it seems like that's got to be true, which is a problem because that suggests that in at least that case, letting die is worse than killing. Non-voluntary euthanasia continues to be ethically controversial, especially because it's not it's sort of in this weird middle category where the patient hasn't explicitly consented, but they haven't made it known that they do not wish to have euthanasia. So when we don't know what the patient would have wanted, then it becomes very tricky to figure out what we ought to do. And I just want to conclude this section of the discussion by suggesting that the deep questions about this concern whether euthanasia should ever be allowed, and if so, what kinds of euthanasia and under what conditions. The present state of things is that passive euthanasia is considered permissible, active euthanasia is considered impermissible, and it's really mostly the voluntary kind and occasionally the non-voluntary kind that we think is acceptable. Yeah, and a lot of the debate turns on whether the active form of euthanasia should be permitted. Alright, so let's talk about some of the arguments for allowing euthanasia. One of the arguments turns on the idea that patients have a right to die, that patients have a right to decide how they want their life to go, including how they want their life to end. So they have this sort of robust autonomy right that includes things like a right to refuse treatment. Now, passive euthanasia can easily be construed as a right to refuse treatment if one wishes, and in some sense all patients really do have a right to passive euthanasia, because any patient at any time can refuse treatment if they want to. But it's not clear that a right to refuse treatment extends to a right to active euthanasia. It's not clear because what you have in the case of passive euthanasia is a sort of right of non-interference, it's an autonomy right. It doesn't impose much upon other people, whereas active euthanasia actually does. If you have a right to active euthanasia, it places strong obligations to help you on certain people. And that's Callahan's concern. So it's worth noting one objection to this argument. Callahan says, look, if you have a right like this, exercising this right requires the involvement of other people. So autonomy isn't sufficient to justify it, because it imposes certain kinds of obligations on others, and so we ought to sort of legitimately and genuinely ask whether people can be obligated to do things like help you die if you want to. Okay. One more argument for euthanasia has to do with physician obligations. So we see one argument that's supposed to follow from patient rights, another argument that's supposed to follow from physician obligations. Now the thought here is that the role of the physician includes the obligation to prevent patient suffering when they're able to do that. And some people think that this obligation extends to an obligation to assist with euthanasia. And what's interesting about the appeal to the physician obligation is that if physicians really are obligated to prevent patient suffering, it seems like we can make sense of they're being obligated to assist with not only passive but active euthanasia. So the last argument, whether patients have a right to die, it seems like we can straightforwardly guarantee ourselves a right to passive euthanasia, but have a harder time with active euthanasia. And whether physicians have an obligation to assist, by appealing to those types of considerations, we can perhaps ground an obligation to assist with active euthanasia. So you get an argument for the more controversial form of euthanasia, the active form. Now Callahan again has some worries that I'll just briefly mention here. He thinks that the scope of physicians' practice ought to be limited to treating suffering of a certain kind, specifically suffering of a medical nature, not what he calls the pain of existence that's associated with terminal illness. So the thought here is that patients who are terminally ill, who want to end their suffering, and that's their explanation for why they want active euthanasia, or why they want euthanasia, that's not a medical form of suffering, and so physicians should be limited in their practice to dealing with medical forms of suffering. And you might worry that this is just a ridiculous claim from Callahan, because clearly physicians are involved in sort of promoting well-being, the well-being of people in other ways than just sort of elimination of physical pain. There are plenty of physicians who deal with psychological factors that contribute to well-being. I mean, there's a sense in which what physicians are doing is promoting health, sort of broadly construed. And so it's not clear why the alleviation of suffering should be limited to sort of the direct treatment of disease and illness, as Callahan seems to think. I mean, that's something you're going to have to think about when you think about the scope of a physician's practice, what physicians really properly should be treating. And you might think that the pain associated with euthanasia is very much a part of the type of suffering that a physician is equipped to deal with and supposed to deal with. Okay, we've seen a couple of critical replies from Callahan, but we should look at some other critical replies that people might raise. One critical reply that is common in this debate, and that I want to just sort of push against a little bit because I think we now have evidence that it's mistaken, is the slippery slope argument. Now, the slippery slope arguments are basically arguments like this. Well, if we do X, then X will inevitably lead to Y, and Y is terrible. So, because we don't want Y to happen, we ought not do X. Some people think these arguments are very convincing. I've seen them pop up a few times on the discussion board and in people's assignments and things like that. These are not always good arguments. But they're not always bad arguments either. There are some people who will try to tell you, oh, well, slippery slope arguments are terrible. No, no, no. The success or failure of a slippery slope argument depends on both the severity of what lies at the bottom of the slope, so to speak, and the likelihood of that outcome. So if your argument rests on some fantastically unlikely or not particularly bad outcome sort of following from granting a certain policy or allowing a certain practice, you don't have a very convincing argument. This is a kind of consequentialist argument. It's an appeal to sort of negative outcomes as justification for certain kinds of policies and recommendations and things like that. And the worry with regard to euthanasia is that allowing active euthanasia is going to open the door to increasingly permissive attitudes about when it's acceptable or even obligatory for people to end their lives. So the thought here is, well, we let people end their lives when they have terminal cancer or, terrible degenerative diseases, but where does that end? What about the depressed teenager or the lovesick divorcee? These people seem to think that they're in horrible pain as well. And so if the cessation of suffering gives people a right to end their lives and have help with ending their lives if they want to, it seems that we have no basis for sort of rejecting or denying active euthanasia to these people if we're going to allow it to the terminal cancer patient and those folks. And the thought here is that there's just no way, sort of a related concern, is that there's just no way of writing legislation that can adequately prevent abuses of this kind. Hopefully you've read the section on the Oregon approach to physician-assisted suicide. The results of Oregon's current program suggests that these arguments are both wrong. Oregon seems to have developed a system where there's yet to be a case of reported abuse, never mind a sort of verified and legitimate case of reported abuse. It hasn't even been reported at all. And also, the lack of frequency with which this is actually practiced in Oregon, despite its widespread availability, suggests that the slippery slope concerns are not legitimate, that in fact people with terminal illnesses are not likely to sort of create a flood of depressed teenagers who want to kill themselves via active euthanasia. And so the thought here is that slippery slope arguments and claims about how difficult it is to write legislation, those are empirical claims, and what Oregon represents is a kind of experiment that disproves those claims. So it seems that if there's something really troubling about active euthanasia, it's not slippery slope worries, it's something else. Another critical reply that we've already sort of discussed, but that we'll just note here because it leads into the last bit of our discussion, is that killing is somehow morally worse than letting die. I've already suggested not only what I think about this distinction, but also how this is sort of supported in some of the discussion of active and passive euthanasia. So this is supposed to be compelling because even if passive euthanasia is morally permissible, because it's a form of letting die, active euthanasia as a form of killing is not. And that's because killing is just way worse than letting die. Notice that this argument, and again, What we're really talking about is the permissibility of active voluntary euthanasia. That's 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 the big debate. That's the big debatable issue for our purposes, but also within sort of the literature and the public, the realm of public opinion. This is the thing that people want to talk about. So if this critical response turns on there actually being a morally relevant difference between killing and letting die, we need to look at whether there actually is such a difference, a morally relevant difference. And to do that, we need to reconsider the case of Smith and Jones. This is described in the Rachels, and then it's sort of revisited in the piece by Winston Nesbitt. Rachel says, imagine two people. First you have Smith. Smith stands to gain a sizable inheritance if his nephew were to die, and so he goes and he kills his nephew. Jones, on the other hand, does exactly the stuff that also stands to gain from his nephew's death, sizable inheritance. Just like Smith sneaks into the house with the intention of killing his nephew, but when he sneaks in, he sees his nephew in the bath. His nephew slips, falls, hits his head. Jones doesn't do a thing. He simply stands there, allows his nephew to die. Now, Rachels analyzes this case, and Rachels thinks that our intuitions, sort of our gut reactions to this case, shows that we actually think killing and letting die are not morally, there's no morally relevant difference there. His thought is that, look, in the case of Smith and Jones, we think what they both did is just equally reprehensible. So Smith is a terrible person because he snuck into the house with the intent of killing his nephew and then actually killed him, whereas Jones snuck in the house with the intent of killing his nephew, and it's just sort of a matter of luck that he didn't turn out to need to kill his nephew. And that demonstrates, says Rachels, that there's no morally relevant difference between killing and letting die, because in this case, despite the fact that one is killing and one is letting die, we think they're both equally reprehensible. We don't think like Jones is not as bad as Smith. And if there was a relevant difference between killing and letting die, such that killing was worse, we would have to say that what Smith did was worse. Now, Winston Nesbitt comes along and says, look, there's an explanation here for why we think that in these cases, both people are equally reprehensible. It's because they were both prepared to do the same equally reprehensible thing. So Smith and Jones were both prepared to kill their nephew. That's what makes them equally sort of awful people. That's what makes us think that what they did is on morally equal footing, is that they both intended to do the same thing, and it's merely a matter of luck that Jones did not have to do it. Nesbitt says, look, the proper way to interpret this is to put it in these terms. So Smith is the same, sneaks into the house, kills his nephew in order to get his inheritance, while Jones does not intend to, he doesn't sneak into the house, doesn't intend to kill his nephew. However, he's in the room where his nephew slips in the tub, falls in his face, drowns, and Jones doesn't help. However, in this case, Jones was not prepared to kill his nephew had he not slipped and fell. So he didn't intend to kill his nephew. He simply neglected to intervene on his behalf when this occurred. So the thought is that there's a difference between these two individuals, and that Smith intended to kill his nephew and was prepared to kill his nephew, and then he actually killed him. Whereas Jones did not intend to kill him, was not prepared to kill him, but went ahead and allowed this to happen once the opportunity, he took advantage of the lucky situation. Nesbitt says, look, in this case, we think Smith is morally worse than Jones. And we think that because having Smith-like people around, people who are sort of prepared to intentionally kill others, is much more dangerous. It's much worse for us as a group to have people like that around than to have people like Jones around, who are just sort of like they don't have good Samaritan qualities. They're not willing to help people in need. They're willing to allow terrible things to happen to people without intervening on their behalf. But they're not they have no intentions of bringing about these terrible outcomes. And Nesbitt says, look, because we think Smith is morally worse, and the reason is his intentions, that shows that we think killing is morally worse than letting die. Here's what I think is probably true about both these cases, and it's a discussion question, so you guys can think a little bit about this too. I want you to think about these two different versions of the case, but here's what seems to be true from these cases to me. It seems that in the Rachel's case of Smith and Jones, the killing and letting die distinction doesn't matter. In both cases, what was done was morally reprehensible, and I think Nesbitt is right. It's because of the intentions of the actor. However, in the second case, number one, I think you can quibble with whether or not, well, I'm not sure whether Smith and Jones are on equal moral footing. Jones is Jones is guilty of a moral failing of some kind by sort of neglecting to help someone that he could easily assist. But Nesbitt is probably right that Smith is worse because of his sort of intention to deliberately kill the nephew. That seems to be worse, and maybe Nesbitt is onto something. But notice that what that shows is that this is an example where killing is morally worse than letting die. But it's not clear why that supports this general conclusion that killing is morally worse than letting die. So what we have from Rachel's is a case where the distinction makes no difference. What we have from Nesbitt is the case where the distinction does seem to make a difference. And what I want to suggest is that what these cases show is that what makes some acts of euthanasia morally permissible and others not are things like the circumstances under which they occur, the intentions of the people involved, and that sort of thing. So that's sort of, I take that to be the lesson of the Smith and Jones cases, is that these things are context sensitive. It depends on the circumstances. We might think that a sort of homicidal maniac doctor who relished assisting with voluntary passive euthanasia because he saw it as a way of sort of participating in the deaths of other people, we might think that that's an objectionable case of letting die because his intention is just morally disgusting. He's doing it for his own pleasure and enjoyment. Whereas we might think that someone like Jack Kevorkian, who assists a patient who voluntarily consents to end their life, and Kevorkian's only intention is to end their suffering and ease their pain in accordance with their wishes, that seems like an unobjectionable case of killing. So that's what I want to sort of leave you with in thinking about the Smith and Jones cases, is that some of you may be tempted to push that these, and Nesbitt and Rachel's, they each think that their cases show either that killing versus letting die isn't relevant to this debate, or that it is relevant in the case of Nesbitt. And I think what both of them end up showing is that what makes a difference for the permissibility of different kinds of euthanasia has to do with the circumstances of the situation. There's a kind of case-by-case suggestion that follows from these cases. But again, this is something for you to think about. So if you disagree, what I wanted to do, and the reason that I interject my own view here, is that you've seen the two sort of extremes, and I want you to get a sense of what the middle kind of moderate position might look like with regard to this distinction. Okay, what's the bottom line here? Well, first, terminally ill people who are fully competent and who seem to genuinely desire to end their lives, that represents a serious problem for a society like ours, because we grant patients a strong autonomy right. We say, look, you have a right to whatever medical care you sort of deem appropriate. And the fact is, there are some physicians who are sort of willing to assist with this stuff. They're just not allowed to do it. This is a serious problem. This is a problem that's not going to go away. And although passive euthanasia, sort of our tolerance and allowance for passive euthanasia is helpful, there are clearly plenty of cases where active euthanasia would be sort of a more humane thing to do. Now, if we take this right seriously, this strong autonomy right, opposition to some of these practices seems to turn largely on the success or failure of slippery slope concerns. Now, the evidence about these concerns is mixed, although I mainly talked about Oregon as sort of evidence that these concerns are false. In the Netherlands, it's sort of a different story. There has been some reporting of cases of involuntary euthanasia and non-voluntary euthanasia that seem deeply troubling and problematic. And so while Oregon seems to tell against the slippery slope. The Netherlands seems to tell in favor of the slippery slope being a real legitimate concern. And I want to suggest that what that tells us is that it matters the way you administer a program like this. Because Oregon shows us that it's possible to avoid these problems, but Holland shows us that it's possible to have a policy that makes them still possible. And so what we want to be is more Oregon-like and less Holland-like, if nothing else. But you might think that no, in fact, these concerns are very legitimate, even despite sort of the success of the Oregon program. Okay, and finally, even if killing makes one a morally worse person than letting die, it doesn't follow that the actions themselves are morally unequal. This is something else that I didn't mention in talking about Smith and Jones, but that I think is worth noting as well. What Nesbitt and Rachels both talk about, the way that they motivate both their arguments is by talking about how we would feel about the agent, right? So in Rachel's case, we would think that Smith and Jones were equally bad people. Whereas on Nesbitt's view, he says, no, we would think that Smith was way worse because of his differing intentions. Now, notice that those aren't really evaluations of the actions. Those aren't about, killing is an action. Killing is something that people do. Letting die is something that people refrain from doing, or something that people do if you don't think that that distinction holds much water. Now, the thought here is that the debate about Smith and Jones, in addition to showing that what matters is the context, I want to suggest that what it doesn't show is what we should make of the morality of these actions. Apart from whether we think Smith and Jones are morally reprehensible, it's not clear what that tells us about the action, just sort of in general, killing, versus the action in general of letting die. So this just sort of further supports the idea that things like the intentions of the agent, the context, the mental competence of the patient, the conditions under which their consent was acquired, these are the things that matter. Not something arbitrary, like whether this is a case of killing or a case of letting die. So what I want to suggest is that that distinction ultimately just isn't very helpful at all. But again, that's something for you to decide and something for you to think about in the course of the discussion board.